So this will be a very quick video regarding the shoulder joint. So first of all, we can see the rotator cuff. The rotator cuff is essentially made up of four muscles. That is anteriorly the subscapularis, and superiorly the supraspinatus, and posteriorly the infraspinatus and the teres minor. We can see that there is no proper muscular support in the inferior side of the rotator cuff, and hence it is something which is very lax and provides a lot of laxity. Along with that, we'll have three ligaments, which are the superior glenohumeral ligament, the middle glenohumeral ligament, and the inferior glenohumeral ligament. If we talk about how they provide stabilization, then we have differentiation as dynamic stabilizers and static stabilizers. In dynamic stabilizers, we'll have all the rotator cuff muscles, that is the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. Along with that, we'll have the tendon of the long head of the biceps. And in static stabilizers, we'll be having all the ligaments, that is the superior, the middle, and the inferior glenohumeral ligament. Okay, understanding this, we'll be able to understand dislocations of the shoulder joints better. We have anterior dislocation being the most common and inferior dislocation being the least common, though it is kind of counterintuitive given the fact that inferior one does not have any muscular support and is something that is very lax. Yet it is found that anterior is greater than posterior is greater than inferior. So if we talk of anterior, there are four types of anterior dislocations. We'll be having preglenoid dislocation, anterior dislocation. We'll be having subcoracoid anterior dislocation. We'll be having subclavicular anterior dislocation, and we'll be having intrathoracic anterior dislocation. So we very well understand that preglenoid is something that the humeral head will come in front of the glenoid cavity, and in the subcoracoid, beneath the coracoid process, the humeral head will be present. In subclavicular, underneath the clavicle, the humeral head will be present, and interthoracic, it will get inside the thoracic cavity. If we talk about the attitude in anterior dislocation, you have to remember that first of all, there will be contour loss, right, of the shoulder joint. The beautiful contour of the shoulder joint that you have, it will be lost, and along with that, there will be abduction and external rotation. It means that you will have your arm away from you and externally rotated. So the test that we can do to confirm that it's an anterior dislocation, obviously, first is the Hamilton ruler test. What you do is simply put the ruler against a lateral epicondyle, and you will see that it touches the coracoid, the acromion process. Sorry. Okay. So if that is the case, then you know for a fact that there is anterior dislocation present, because the humeral head is not in its place, which will not let the ruler touch the acromion process. Then we'll have the Callaway test, which is basically measurement with a tape, right, to see the overall circumferential difference that exists in a non-dislocated and a dislocated shoulder. Then we have the Dugas test, whether we can touch the opposite shoulder or not, because for that, to do that, you will need to do adduction and internal rotation, so that with your dislocated, if you have dislocation, then you will not be able to touch your other shoulder. And in Bryant's test, you will see that the axillary fold in the dislocated shoulder is lower in comparison to the normal other side of the shoulder, right. The most common nerve injury over here will be the axillary nerve injury, where we will be having both motor loss as well as sensory loss. Motor loss will cause loss to the deltoids and the teres minor, and sensory loss will be having over the deltoid region. That will cause the regimental bat sign, a very important clinical vignette. Along with that, in investigations, we'll send for an X-ray, and in X-ray we'll need two views, that is APV and lateral view. The reason being, in a simple APV, we cannot really differentiate whether it's an anterior dislocation or posterior dislocation, and we need to see it laterally to appreciate the fact that it's an anterior dislocation, right. Whereas in posterior dislocation, if we talk about it, there's just I mean, you do need an AP and lateral view, but there's a famous light bulb sign which on seeing you can tell that maybe it's a posterior dislocation, but it's always suggested that you go for a AP and a lateral view, right. Now talking about reduction techniques, first we'll have the modified Cocker's technique, doing the team procedure, if I have to say it. So in team, the T means traction, the E means external rotation, the A means adduction, and the M means medial rotation, right. So that what happens, we first give traction to the hand to pull it out, then we do external rotation, then we do adduction so that the hand comes inside, and then we give a medial rotation. For cricket lovers, you may have seen Rohit Sharma doing modified Cocker's maneuver on himself in the field. And if in case you cannot do reduction, first of all, being a good doctor is basically, as my teacher said, if you're a good doctor, if you're doing close reduction, you have to give analgesia, obviously give pain management. But if still close reduction does not happen, you take the patient to OR and you give anesthesia and do close reduction. If still reduction does not happen, you open up the patient. Obviously, you're going to do it under anesthesia, under general anesthesia, right. Next technique, that is Stimson's technique, which is basically hanging in weights and you lying down prone. In like third place, we can do Hippocratic technique, where basically it's very barbaric. You basically put counter traction to the patient with your own foot, and then like pull their hands so that the dislocation gets corrected. Now talking about the very important part, which is the complications arising out of these. Okay, so what happens is like the recurrent shoulder dislocation, something that is very common, and that is something that happened with Rohit Sharma, is because of which he is able to do Caucasian himself, because he knows and he has had a previous situation as such. Okay, so why do recurrent shoulder dislocations occur is because when the humeral head comes out from the front, right. So what it does is it detaches the glenoid labrum. Okay, it tears away the glenoid labrum with itself antero-inferiorly. Okay, and that is called as the Bankhart's lesion. Okay, and what happens sometimes, this glenoid labrum, while it is detaching, while it is tearing off, it causes an avulsion fracture along with it, right. So it is basically avulsion fracture of the glenoid, and that is called as bony Bankart, right. And what happens is, this is Bankart lesion, bony Bankart lesion, and along with that, if we talk of something else, then what happens, this is the humeral head, right. It comes out, but then it gets hit on the back, right. This causes an indentation on the posterolateral aspect of the humeral head, right, on the humerus, and that causes something called as Hill-Sachs lesion. Okay, so this is all that you need to know for anterior dislocation. And then comes the easy part. If you have posterior dislocations, then what is the mechanism of having posterior dislocations? High voltage muscular impact. It means, say someone is having a lot of seizures and they fall down, they have a Fuchs injury, that's fall on ostrich hand or something of that sort. Then when the muscle is in a lot of tension is when you can have posterior dislocation. Okay, so the attitude in over here will be exactly opposite to that of the anterior dislocation. Here we will be having adduction along with internal rotation, and the interesting thing in this is that the contour will not be lost. In investigation you send for x-ray, and obviously you send for AP lat, and you'll find the classical light bulb sign in the AP view. Yeah, and obviously the most common nerve injury here too will be the axillary nerve, and the complications in over here will be exactly opposite to that of your anterior dislocation, though the mechanism being same. So hitting the same spots, right? Basically the posterior glenoid labrum tearing out, that is called as reverse Bankart's, and the posterior glenoid labrum, say when the bone is coming out, when the humerus is coming out, the anteromedial part of the humerus, gets hit with the posterior rim of the glenoid labrum, right? And that causes reverse Hill-Sachs lesion on it. And then we have the very easy inferior dislocation, which is luxatio erecta, which is called as luxatio erecta, where the mechanism is something that is important for it. So here you will be having hyperabduction, okay, hyperabduction injury, and you can expect this when, say, you are falling down from somewhere, in gymnastics, for example, those people who turn around certain bars, for them they have a lot of hyperabductions, and in that case, when you're falling and you hold on to something, that is when you will have a hyperabduction, okay. And obviously fush can also take place. And the treatment for all of this is mostly obviously if you can reduce, then it's good, but if you want surgical treatment, if there is need of surgical treatment, then you simply do Bankart's or Hill-Sachs repair arthroscopically. Yeah, that's it.